Dr. Srinivas, how are you, my friend?
Hello, sir. Good evening. I'm fine. Thank you. How are you,
Evening,
sir?
It's nice to see you again.
Yes.
Thank you so much for joining us, sir.
My pleasure, sir. Thank you. Thank you for
Thank
the
you, sir.
invite. It's an honor.
We have 10 speakers tonight, sir, from Egypt, India, UK, and Italy.
It's a good program, sir.
Thank you so much, sir. Thank you so much. Dr. Hassan, how are you, my friend?
Hello.
Dr. Hassan from Italy. Thank you so much for joining us, sir.
I am fine, thank you. And you? It is a pleasure to be here.
Thank you so much. It's an honor for us, sir. Thank you so much.
You are more than welcome, Professor Muhammad Gamal Ashhab.
Thank you so much, sir.
Thank you.
We have just 1 minute to start. Dr. Maher, would you like to try sharing your screen, sir, before we start? You are the first speaker, sir.
I am ready, inshallah.
Would you please share your screen, sir, just as a test?
Share option. Is it okay?
Yes, sir. It's okay. Full screen, please, sir.
سيادة العميد شايف الصورة دلوقتي عندك؟
شايفينها يا أستاذ، شايفينها سعادتك. فول سكرين بس يا أستاذ. عايزين فول سكرين سعادتك.
حاضر.
Okay, sir. May I start, sir, please? I introduce all of you, sir. Bismillah ar-Rahman ar-Rahim. It's a great honor for me to announce for another day in the Specialty Day course. Tonight we have the Knee Specialty Day with 10 eminent speakers from 4 countries, Egypt, India, UK, and Italy. Many thanks for our eminent guest speakers for joining us in this very fruitful scientific night. Our first speaker will be Professor Maher Al-Assal from Egypt Asyut University, one of the eminent stars of knee surgery in Egypt and all over the Arab world. Professor Maher will speak about a successful ACL surgery, a teamwork concept. Professor Maher, please. Thank you so much for joining us, sir.
Thank you, Mr. President, Dr. Muhammad Gamal Ashhab, and my dearest gratitude to all our colleagues from all countries. And I have an honor to introduce my title as a successful ACL surgery, a teamwork concept. Bismillah ar-Rahman ar-Rahim. Success rate of ACL reconstruction has been reported to vary between 73 to 93, as reported by Fethian in 2005. A return to the previous activity level and for recovery is one of many considerations. The introduction consists of many issues: the pre-operative consideration, operative, post-operative, return to play, prevention of re-injury. The initial treatment is to get knee feeling well or prehab. Reduce swelling, get motion, and get quadriceps strength. How? Reduce swelling by ice, compression, non-steroidal anti-inflammatory drugs, and aspiration. And get motion by restoring full flexion and full extension. Get quadriceps strength by quadriceps drilling and many other exercises to restore the quadriceps strength. And CKC or closed kinetic change exercises involve movements where the foot is or both feet is fixed to the ground. Get the knee feeling well by rehab. So the better you are going into surgery, the better you will be coming out of surgery, right? Make the correct diagnosis. Recognize any associated injuries like posterolateral, posteromedial, corner injuries, ligaments, meniscus, and the cartilage injuries. This is very important. The time interval as timing for the ACL reconstruction, time interval is not as important as the condition of the knee at the time of surgery. We mean for range of motion, minimal effusion, minimal pain, and the mentality preparation. Avoid use of tourniquet because it decreases thigh circumference and it delays the quadriceps activation. So tourniquet use in arthroscopic anterior cruciate ligament reconstruction. This is a systematic review and meta-analysis of randomized controlled trial. It is recommended. The right graft for the right patient. The ideal graft should produce the anatomic biomechanical properties of the native ligament. Also allow solid fixation and rapid biological excuse me, with minimal donor site morbidity. To date, no graft fully meets all these requirements. All are strong enough. All are strong enough. Like the patellar tendon, the hamstring, the quadriceps, and the peroneus longus graft. 5, correct tunnel position, not too high and not too low, and should be almost in the anatomic position. Other operative consideration to know multiple ways to fix the ACL, interference screw, button, etc., etc. Number 7, fix the meniscus when possible, especially medial, because lack of medial meniscus places stress on the ACL. Another operative consideration is to consider ALL or anterolateral ligament reconstruction with these conditions: high-grade pivots, high-risk athletes, hyperlaxity, and in revision cases. Immediate post-operative consideration to reduce swelling and apply early physiotherapy immediately after surgery. Reduces swelling by cryotherapy and compression. Evidence-based medicine studies proved a great benefit of post-operative cryotherapy and the limited evidence to draw certain conclusion about compression isolated and with compression the same. Early physiotherapy to restore range of motion, strength while protecting the graft. Early motion, activate quadriceps and strengthen hamstring. Get extension early. This is very important issue. Get on bike is great for knee range of motion, great for quadriceps with minimal stresses on the ACL reconstruction. Again, get extension. If don't get it early, then hard to get. Use extension device if having troubles. Successful return to play. It's a team approach. When to return to sport? No clear-cut answer so far. Time of return to sport. Young athletes who return to sport before 9 months after ACL have new injury 7 times that of those who delay return. 7 times. The optimal time for return to sport after ACL reconstruction remain an ongoing issue. Return to sport criteria. This is from my own thinking. 5 B's program. Number 1, physical criteria. I will explain in the next slides. Physical criteria, psychological criteria, performance criteria, proper imaging criteria, and finally, play criteria. The top listed one is the physical criteria. We should have no pain, no swelling, symmetrical range of motion, and good stability. This is the physical criteria. Psychological criteria is also very crucial issue because fear of pain or re-injury due to movement, which is called kinesiophobia. 50% of non-returner in Moon study is the multi-center orthopedic outcomes network, cited fear of re-injury in 50% of non-returner. So a well-balanced and motivated athlete performs well. A sport psychologist can play a huge role in recovery. Performance criteria, quadriceps and hamstring strength should be more than 90% of non-involved limb, and this could be done by the myometry machines. Hop index more than 90% of non-involved limb. Plyometrics exercises to build up the muscle power and the speed and also the flexibility by many exercises for this. Optimal neurovascular control and sport-specific training for each specific sport. Number 4, proper imaging criteria to prevent graft re-injury, safe return to sport at the proper time. The graft is completely healed. The graft should be completely healed, and this could be by imaging consideration. So MRI is an indirect assessor of graft maturity. The lower the signal intensity, the more mature the graft. So the lower the significant intensity, the more mature the graft. Okay. Like this picture, how black the ACL reconstructed could be. Another important issue in imaging is the MRI signal to noise coefficient is better than MRI signal intensity. It is better because it depends on numbers, not on our eyes. So initial increase in signal to noise coefficient peaking at 6 months over time. Like this picture, we can see sagittal T2 with fat suppression stair image showing the region of interest with a diameter of 25 pixel here. This is number 1, this circle. And the second circle on the posterior cruciate ligament, and the third circle on the air outside the knee. All should be black, but the black color is different from 1 to 1. So there is a equation as ACL region of interest, this is a number, equal signal ACL, number 1, minus signal PCL on signal background noise. Background noise is the air outside the knee. This should be a figure, or should be a value, or should be a number, and it is more reliable than my eyes. Okay? This is done by the radiologist. Play criteria. Return to practice game entails gradual increase time, intensity up to 100% effort. 100% effort. Okay? So progress from game simulation to friendly game to competitive sport. Okay? This is play criteria. This is the last item in this issue. And another important issue is to prevent re-injury after ACL reconstruction. Proper warm-up prior to technical and tactical training. This is very important, the warming up. Enhance performance should be continuous, and continue neuromuscular training for the remainder of their career. So, to conclude or to summarize the successful ACL surgery and the recovery as a team work concept, we start pre-operative consideration by prehab, operative, the right graft, the right tunnels, the treatment of associated injuries, etc., etc. Post-operative, to treat swelling, get motion, get quadriceps active, hamstring strong, and then return to play. No hurry to return, and should we follow these 5 B's that I have mentioned few minutes ago. And finally, prevention of re-injury. So to be a teamwork is not only as a surgery for ACL to be successful, but also other issues, pre-operative and post-operative, and issues to return to play. This is a teamwork concept. Alhamdulillah. Thank you very much.
Thank you so much, our dear professor, Professor Maher Al-Assal, Asyut University. Sir, we have just only one question. في عندنا سؤال يا فندم. Is there basic rules for sports specific training and follow-up?
Excuse me?
Is there specific basic rules for specific training and sports specific training and follow-up?
We should follow this sport mean up for many criteria that I have mentioned a few minutes ago in the post-operative, until we fulfillment the 5 P's I have mentioned to return to sport.
Thank you so much, sir. Thank you so much, Professor Maher Al-Assal, for joining us. And we should move to our next speaker. Next speaker will be Professor Hussam Al-Shafei from Alexandria University, Egypt. Professor Hussam, one of the cornerstones of EGA Arthroscopy Association in Egypt, and one of the eminent stars of arthroscopy in Egypt and all over the world. Professor Hussam, thank you so much for joining us, sir. Professor Hussam will speak about patellofemoral instability when you need to operate. Thank you so much, sir.
I need to share down. Can you take this?
Yes, Professor Maher, ممكن stop sharing screen يا فندم بعد إذن سعادتك؟ استاذنا دكتور ماهر احنا just press stop sharing. تمام، اتفضل يا دكتور حسام بيه، اتفضل يا فندم.
انا ادور بس اجيب الشيرنج ازاي؟ ده البرزنتيشن هنا.
سعادتك هتفتح البرزنتيشن يا دكتور حسام، وفي تحت الجرين بوتن شير سكرين هتشير منه يا فندم.
جرين بوتن، ثواني يا حبيبي. انا فتحته بس
في تحت سعادتك جرين بوتن شير سكرين.
اوكي.
يس 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 سير، فول سكرين سير.
That's okay?
Yes, sir.
Okay, so thank you, Dr. Hamad Al-Ashab, for inviting me for giving this talk. And I'd like to say hello for our colleagues from other parts of the world and from Egypt. Happy to see you today. And inshallah, I wouldn't take more than 15 minutes for my presentation. Right. I'm going to, can you hear me, everyone, and see? It's okay? Right.
Yes, sir.
I'm going to talk about patellofemoral instability when you need to operate and what are the options. أنا بس في خط كده طالع لي في النص مش عارف أشيله إزاي.
هو السكرين يعني باينه قدامنا يا استاذ.
Right, okay, fine.
Yes, sir.
First, I'm going to give you a presentation of case, and then we talk about this case in the middle of the talk. Case 1 is a 23 years old female. She has first time of patellar dislocation 4 years during sports. She has recurrent dislocation about 3 times in the following years. She's complaining of left knee instabilities, anterior knee pain, and unable to squat, and has difficulty on stairs. And she's also unable to participate in sports. Right, on examination, this is a clinical examination. She has a full range of motion. She has a positive jumping J sign, as you see in the video. And she has a positive apprehension test, mild patellar tilt, no geniovalgum or torsional problem, and she has stable ligaments. Right, this patient has been studied radiologically by X-ray, CT, and MRI. And the data we obtained from this study, she has a TTTG ratio more than 20. She has a trochlear dysplasia du jour type B, mild patellar alta, and patellar tilt about 50 degrees, patellar subluxation, and of course, she had a torn MPFL. Right, so this is the patients and the data and how we assess this patient. First, we're going to do some study about the outlines of the condition, by definition, history, physical examination, imaging, and the treatment options. And this data is going to be described in the following slides. Right. We know that patellofemoral instabilities, which has a repeated subluxation and lateral dislocation, can happen with a minimal trauma, just a twist, and more common in adolescent females, may be bilateral, and the reported incidence about 29 per 100,000. Recurrence rate about 15 to 44%. These patients has predisposing risk factors like general factor, ligamentous laxity, previous traumatic event, and miserable malalignment syndrome. Anatomic factor like patella alta, trochlear dysplasia, patellar dysplasia, and excessive lateral patellar tilt, and dynamic factors that like dysplastic VMO, vastus medialis obliquus, and overpull of the lateral structures like ITB and vastus lateralis. These patients have a history. When you study this patient, first time, we need to know the first time of dislocation, when it's happened, and how it happened, the mechanism of injury, and how frequent in the following years, and also the direction of instability, which is most commonly lateral instability. Physical examination, standing examination, very important to examine the patients while he's walking to your office, like to see how it walks, how she walks, and to see the malalignment of the lower limb, like femoral anteversion, valgus knees, external tibial torsion, miserable malalignment, which is a combination of the above ones, and excessive lateral position of the tibial tuberosity. All these factors can increase the Q angle clinically. Also, sitting examinations, we examine the patellar tracking, jumping J signs, and active extension may elicit crepitation in the old cases. As you see here, all these 3 cases have a jumping J sign. A positive J sign indicative for patella alta and trochlear dysplasia. Examination and the lying down, which is you need to see the patellar grind, apprehension test, patellar hypermobility, patellar tilt, and Q angle is measured clinically, as you see in this photo. Prone examination, the patient is placed in the prone position to assess for rotational deformities. Increased femoral anteversion is diagnosed when the internal rotation of the hip is greater than the external rotation. Now we go to the radiological evaluation. First of all, we need to do an X-ray, AB, lateral, and Mershown view. How we obtain the data from this X-ray. The lateral view is very beneficial in a 30 degrees of flexion and gives an idea about the patella level, like patella alta or patella baja, and also give an idea about the presence of a crossing sign, which is an indicative of trochlear dysplasia. The axial image, which is called Mershown view, it should be done in this 2 only, this has been is not accurate. So this will give you the idea about the proper visualization of the patellofemoral joints. And this view, we can obtain several angles like sulcus angle, congruence angle, and lateral patellofemoral angle, and patellar tilt angle. Next, CT scan. This is a Lyon school for examination of a CT scan. You need to see the TTG, tibial tuberosity trochlear groove distance, patellar tilt angle, and femoral anteversion, and external tibial torsion. The TTTG angle is a distance between the center of the trochlea, and the center of the attachment of the patellar tendon to the tibial tubercle. If it's more than 20, this means this patient has an external tibial torsion or lateralization of the tibial tuberosity, which can happen in any other pathology I mentioned previously. This TTTG ratio is actually a mimic for a clinical evaluation by Q angle. Trochlear dysplasia can be assessed either by the CT or MRI, which is increased sulcus angle more than 150, and it's been classified by Dujour into four types. He actually described this in the lateral view of X-ray, just an X-ray, where the crossing signs you can see in the pictures here. If you look to the normal side, you will find this is a line representing the deepest part of the trochlear sulcus, and this is the line representing the highest point of the trochlear of the femoral condyle. This should be parallel normally. However, in trochlear dysplasia, this line crosses the other line and is not parallel. And also, you can observe here an elevation of the anterior part of the femoral sulcus, which we call trochlear spare. Grade 1, as you see here, it's a mild Dujour classification at about 160 degrees. Grade 2 is a flat sulcus or convex sulcus. You can find that, you can see here the crossing sign and the tubercular spur, and this is the CT pictures, and this is the clinical picture. Grade C is what we call lateral facet convex here, and with a hypoplasia of the medial facet, of the femoral condyles. And you find all this data, crossing sign, supratrochlear spur, and double contour. Grade C, this is a picture of the grade C. Grade D, which is a cleft pattern, where you can see a symmetric of the trochlear facet and the cleft pattern of the femoral condyle, and also you can find all this data in presence. Right. MRI, the value of the MRI, you can assess the intra-articular pathology, as well as the damage or torn MPFL, and also you can assess the trochlear dysplasia and patellar height. Right, back again to our case, the data we obtained, the TTTG ratio more than 20, which means lateralization of the tibial tuberosity, trochlear dysplasia Dujour B. She has a patella alta, patellar tilt, and patellar subluxation and torn MPFL. All this pathology are actually play a part in the lateral subluxation of the patella and recurrent dislocation. So the plan here to correct every part of this pathology. The patella alta, by Cadon-Deschamps, is a more than 1.5. We will do TTO distalization. Patellar tilt angle 53, so we have to do lateral retinacular lengthening. In the past, we used to do lateral patellar tenotomy, and the trochlear dysplasia Dujour B will do trocheoplasty and TTTG ratio more than 20. So we'll do TTO medialization as well as distalization, as we described it before. And lastly, we'll do MPFL reconstruction. Surgical order, we take the graft first, which is the SIMITI, and we'll start with TTO osteotomy and with no fixation, and then trocheoplasty and fixation of TTO with distalization and medialization, and we do lateral patellar lengthening, and finally we do MPFL. Here, this is the video quickly. You see the patella is dislocated, and first we'll do midline incision, as you see here quickly. Yeah. and after that we do medial arthrotomy, and after we do the medial arthrotomy, we do TTO osteotomy, tibial-tuberosity osteotomy, and we reflect it on the lateral side, as you see in the second video, to expose the femoral condyle. And then we started to plan our trochleoplasty. First, we do dissection of the synovium from the edge of the cartilage for later repair, and then we plan the osteotomy by drawing the new condyles. As you see here in this video, she has a double contour of the femoral condyle. And then we use a saw or osteotomy to remove the supratrochlear spare. This is the most important issue in trochlear dysplasia, to remove the supratrochlear spare. You can do it by saw, or you can do it by osteotomy, as you see in the photos. Following after that, we remove the supratrochlear spare by Nibbler, and you see this gap in here. And after that, we start to do use this high-speed burr to remove decancellation of the subcondylar part. And the most important issue in here is to leave between 3 to 4 millimeters of subcondylar bone to avoid articular cartilage necrosis. And then after you feel it, you're done the decancellation of the subcondylar bone, and you feel the femoral condyle becomes mobile. We do osteotomy using a knife in the middle of the new created sulcus, as you hear, and you see in the other photos. After that, we fix it with 2 Kirschner wires or 2 staples, or you can use 3 knotless anchors. However, this is extremely expensive nowadays, and we use these ones as a replacement. But it looks fine, and at the end, you can observe here, this is before the surgery, before the trochleoplasty, and here after the trochleoplasty has been done. After that, we do lateral patellar lengthening. We cut the superficial part proximally and the deep part distally, and we sew it together. And then finally, we fix the TTO with 3 screws, and we do MPFL reconstruction. Okay? And it's the patient before surgery. You can see the jumping J sign. After surgery, at 8 weeks, she has nearly a full range of motion and negative J signs. This patient, 8 weeks after surgery, she's walking unaided, and this is 4 months post-operative. She has a full range of motion with no pain, and she is happy. The second case I would do just quickly with this patient. Is that okay to do the second case, or finished? To Muhammad.
No,
Hello?
sir, you can do it, sir, please.
Stop at that point.
No,
Okay.
sir, no, sir.
I
Continue,
can't
please.
hear you.
Continue, please, sir. Continue.
Okay, fine. The second case, she has a full range of motion, positive J sign, and both apprehension tests, mild patellar test, no geniovalgum, no torsion problem, and stable ligament. You can see the jumping J sign. Radiology, she had a TTT duration more than 20, trochlear dysplasia, du jour C, patella alta, patella subluxation, and torn MPFL. And the plan here is to do TTO distalization, trocheoplasty, and TTO medialization, and MPFL. Surgical order, same surgical order. We take the semitendinosus, and then we do TTO, no fixation, trocheoplasty, fixation of TTO, and finally MPFL. Medial arthrotomy as before, and then TTO, as you see in the second video, and then reflected the TTO, and final, and then expose the femoral sulcus, and we plan our trocheoplasty. Here I used an osteotome to remove the supratrochlear spur here, as you see, until it becomes the flap mobilized, and I use a high-speed burr in the other video. And you see here, this is a very nice video. You really need to see this position. Mobilization of the flap. If it's mobilized and it goes down, and then you can cut in the middle and fix it as we did before, as in here. as you see in the other video in here, right? And finally, and the next, we fix the TTO with 3 screws by distalization and medialization. And finally, MPFL reconstruction, and the patients should go for a full range of motion to test for your stability of the patella. This is the X-ray after operation. You can see here the creation of the sulcus. And this patient, 2 months post-operative. Another, and here you can see here the jumping J sign, and then and the second video it disappeared. 4 months. She had a full range of motion, as you see in the videos, and she's ready for the other side. My series about 11 cases, 9 females, 2 males. Stiffness happened in 8 patients, required MUA at 6 weeks. All patients had a full range of motion, no trochlear necrosis, no recurrent patellar dislocation, and we have now 3 years follow-up. These are male patients, about 2 years. He had a full range of motion, no problems. And another patient is now back to normal activities. In summary, no single finding responsible for all patients, for all patellar instabilities. Tailor your surgery for the pathology. Most common surgery, MPFL reconstruction, distal realignment, trochleoplasty. Please do not miss malalignment. Thank you very much.
Thank you so much, sir. Professor Hussam, fantastic presentation. Thank you so much, sir. If you have any questions. Thank you so much, Professor Hussam. You can hear me, sir?
Yeah, I can hear you now.
Thank you so much, sir. Fantastic presentation, sir. Thank you so much. I think we have no questions. So, sir, we have to move to the next speaker.
Right.
Next speaker. Thank you so much, sir. Next speaker will be Professor Abdurrahman Ganaini, Mansoura University, Egypt. Professor Abdurrahman will speak about updates in medial ligament knee injuries. Professor Abdurrahman, please.
ثانية واحدة محركة.
اتفضل يا فندم.
شير سكرين.
Yes, sir. هو بس نبدا البرزنتيشن من الاول يا دكتور عبد الرحمن بيه لحضرتك في النص. ايوه تمام. تمام كده يا فندم. تمام سعادتك. اتفضل يا فندم سعادتك.
السكرين باينه؟
باينه يا فندم سعادتك.
تمام. بسم الله الرحمن الرحيم. الحمد لله رب العالمين والصلاه والسلام على اشرف المرسلين. Now I would like to thank Dr. Ashhab for his great effort over many years in presenting this wonderful scientific content, and I wish him to continue without interruption. And also, I am welcoming to meet my colleagues and professors from Egyptian side of IGA and from over the world. My injuries to the medial collateral ligament complex of the knee are the most common ligamentous lesions. Direct outside of the knee with the foot planted, producing direct valgus stress, as we see in. Can medial collateral ligament of the knee heal? There is a long consensus that medial collateral ligament heal without the need for surgical intervention. However, some injuries progress to sequelae of missed MCL, the ACL or PCL reconstructed if combined with them. Because the medial thrust may be identified on gait examination. Layers of the medial side of the knee. Layer 1 is the sartorius and sartorial fascia. Between layer 1 and 2, gracilis and semitendinosus, and the superficial medial collateral ligament and posterior oblique ligament, and the semimembranosus tendon, and the layer 3 is the deep medial collateral ligament. As we see in this photo, this is the sagittal view of the knee. This is the patella and dial, and this is the adductor tubercle, and this is the gastrocnemius tubercle. The insertion of the superficial medial collateral ligament inside this triangle, and then inserted into the tibia upper medial part, 6 to 8 centimeters from the joint line. And if we remove the ligament with its two components, the meniscofemoral part and the meniscotibial part, of the posterior oblique ligament, which is very important, it has three arms between the superficial arm and the central arm and the capsular arm. The superficial medial collateral complex has a very important role to restrain valgus stress in all angles of flexion, while the superficial medial collateral ligament primary strain collateral ligament is the secondary restraint to valgus stress, while posterior oblique ligament is the primary restraint to internal rotation of the tibia. This is the deep medial collateral ligament, as I told you. It important in restrain cadaveric, and this is the layer facial fascia and the hamstring tendon. We can see the superficial medial collateral ligament and the posterior oblique ligament as we see them. This is superficial oblique. Another, and this is the semimembranosus tendon insertion. If we remove this, we medial collateral ligament with its two components, tibial part. So the tension of the whole ligament are different. When we have medial capsule are tight in extension, while the superficial medial collateral ligament is as we see the superficial and the posterior oblique ligament section as you ligament becomes more relaxed, and this is the superficial. With external rotation, as we see external rotated tibia, it will be restrained by the posterior oblique ligament. Lateral ligament as we see with internal rotation. So if we have a very important to see the mechanism of injury, and the velocity of the injury plays a very important role. Low velocity injuries such as twisting injuries during the sport results in trauma. Road traffic accident may result in injury to the medial. Complete physical examination is very important to determine location and extent of chronic injury. As we see in this photo, this is the medial side medial collateral ligament injury. Valgus stress is very important to do it in 0 degree of extension and in 30 degree of flexion. Increased valgus gapping in 30 degree indicates isolated MCL, but in 0 extension, it will indicate injury to the posterior medial capsule. Amount of Houston was subdivided into 3 grades: grade 1 mild, grade 1 is mild, and grade 2 5 to 10 centimeter, and grade 3 more than 10 centimeter. It calls severe injury. Now, how can we examine the
دكتور عبد الرحمن بيه الصوت بيقطع شويه.
الصوت بيقطع؟
بعد اذن حضرتك.
محمد سامعني؟
سامع
كده؟
سعادتك بس هو بيقطع بسيط.
طب كده
اتفضل يا فندم.
كويس ولا؟ The posteromedial examination maneuvers like anterolateral drawer test, anteromedial rotatory instability test, anteromedial drawer test, and drawer test, anterior posteromedial corner is affected. In anteromedial rotatory instability, the patient also is supine, but the knee is flexed about 30 degrees. Rotated, and then we apply our anterior subluxation of the medial tibial plateau indicates also posteromedial corner injury of the knee. So besides this, capsule, a detailed clinical assessment posterolateral corner. Also, we don't forget neurovascular assessment is very important, especially in X-rays. We have to do plain X-ray to see if there is avulsion fracture or associated fracture of the lateral femoral condyle. Also, we can see calcification over the femoral ligament, indicate chronic tear of the medial collateral ligament. And also we have to do valgus stress test and to see the opening, how much is the opening in millimeters. Labrad suggests that than 3.2 millimeter in the medial joint space in 20-degree flexion suggests MCL tear, while more than 9.8 suggests complete MCL and posteromedial corner. Opening more than 13 millimeter. If there is gapping in zero degree extension about more than 6.8, this means that there is complete knee injury. And for we can do stress radiograph in under anesthesia to confirm our diagnosis. MRI is very important. Injury into 3 grades. Grade 1, grade 2 indicates partial ligament tear. Grade 3 indicates complete tear of the ligament. Into 3 types. Type 1, avulsion from the tibial end, but ruptured end is still below the base anserenius. Very important. And this type is below the base anserenius, but type to the base anserenius. And the type 3, the medial collateral ligament is entrapped inside the medial joint space. As we see in also in MRI in this photo, you can see the lateral femoral condyle, and this indicates the high velocity injury. And we can see also the extruding lateral meniscus. Usually we have lateral meniscal injury with severe medial collateral ligament injury. And see interruption of the medial collateral ligament. Therefore, one must combine the result of clinical assessment, stress radiograph, and MRI evaluation to conclude the extent of the injury and the possibility of examination. If we have this is one of the indication of surgery. You can see the medial rise, as I told you, this is very important sign to decide you have to do surgery. In the presence of this valuable arthroscopic sign structure,
دكتور عبد الرحمن بيه الصوت بيقطع جامد يا فندم، احنا مش سامعين حاجه. دكتور عبد الرحمن بيه.
If we can see in this is the media.
الصوت بيقطع جامد يا فندم.
محمد مش سامع كده برضه؟
كده احسن يا فندم.
كده افضل؟
ايوه يا فندم.
تمام. طيب اعيد اللي فات يا محمد، السلايد اللي فات سامعها؟
سعادتك اعيد دي بعد اذن حضرتك يا فندم اللي فاتت. شكرا يا فندم.
ارثروسكوبيك اكزامينيشن، سامعني يا دكتور محمد؟
ايوه يا فندم سامع سعادتك.
Arthroscopic examination, an excessive opening of more than 1 centimeter of the medial femoral and the tibial condyle during arthroscopy is known as medial drive-through sign. And this is very important sign to decide this patient will need surgical intervention to address the medial collateral ligament. And also we know the meniscal rise sign. This is very important sign also in arthroscopy to do reconstruction or repair of the medial collateral ligament. So in presence of this valuable arthroscopic signs, a combined reconstruction of ACL, MCL is recommended even for grade 2-3 injury to decrease the frequency of failure rates and residual medial laxity. In this photo, we can see this is medial collateral ligament injury from the femoral side, and this is the medial collateral injury from the tibial side. And this is medial collateral ligament mid-substance injury. We can see by arthroscopy. And also, if we see the meniscus is floating like this means that the deep medial collateral ligament is injured. And this, as I told you, is an important sign for reconstruction or repair of the medial collateral ligament. So the treatment, the management of medial side injury of the knee is very important. Whether conservative or operative depends upon several factors: grade and level of medial collateral tear, type of medial side injury, whether is isolation or in combination with cruciate ligament, and also chronicity of the tear. The treatment indications for operative treatment of MCL injury includes the following: large bony avulsion, a concomitant tibial plateau fracture, associated cruciate ligament, or intra-articular entrapment of the end of the ligament, as I told you before. So conservative treatment is for isolated acute superficial medial collateral ligament, whether 1, 2, or 3, and deep medial collateral ligament, femoral end MCL tear, which has a higher probability of healing, low-grade superficial medial collateral ligament tears, along with ACL, PCL tears. In conservative management, grade 1 just weight pairing is tolerated with crutches if necessary, and active range of motion is started early. Grade 2, we can do use long leg brace for ambulation for about 1 to 2 weeks. But in grade 3, immobilization in long leg brace is important for 3 to 6 weeks. The controversy is present when the ACL is injured with the grade 3 MCL. How can we do? There are two relevant controversies regarding high grade MCL with ACL injury to repair or not, and also early or delay ACL reconstruction. Although most surgeons recommend the conservative management of grade 3 MCL for 6 to 8 weeks, followed by ACL reconstruction, recent studies suggest that inadequate healing of the conservative managed medial side could trigger the failure. And so there is controversy to do reconstruction or to delay the reconstruction. Recent data from Danish knee ligament reconstruction registry also favor MCL reconstruction in isolation and combined injury to restore valgus stability. And also comparing data of about 20,000 patients from the Swedish registry report, non-surgical treatment of a concomitant MCL and ACL may increase the chance or the risk of ACL revision. So in case of ACL, also the treatment is controversial, as I told you. It is important to note that a grossly unstable medial side of the knee is characterized by medial gapping in zero knee extension. If there is medial gapping about 6.8 millimeter, this suggests the posteromedial capsule structures are damaged, and so you have to reconstruct. So in acute MCL posteromedial capsule injury, there are also two schools. One is a two-stage surgery. We address the medial side injury first by primary repair, followed by knee mobilization, and then subsequently intra-articular ligament reconstruction after healing of the MCL. Or single stage surgery or repairs and reconstructions are performed together with excellent outcomes. From the start, we do the ACL or BCL reconstruction with the MCL reconstruction or repair. And there are challenges as increased tourniquet time, the possibility of infection due to prolonged surgical timing, deep vein thrombosis, knee stiffness, complex regional pain syndrome with the acute repair and reconstruction of all the ligaments. So repair technique, examination under anesthesia and arthroscopy, as I told you, and then we can do, if it is avulsive from the femoral side, we can do stable fixation, or and also if we have deep medial collateral ligament injury, we can do a repair by suture. Or by suture anchor, we can do both anchor in the femoral and tibial side and repair the posteromedial capsule. Also, we may do internal bracing in acute injury to do fiber tape and to do both a swivel lock for the femoral and tibial side with the and with isometric point to have good flexion and extension before fixation, as we see. Also, plasma-rich growth factors may have good beneficial role in the treatment of early repair of the MCL, especially in athletes. MCL, when we do reconstruction is indicated if the native tissue quality is poor or the ligament failed to heal after conservative treatment, and also with femoral osteotomy in valgus aligned knee. For MCL and posterior oblique ligament reconstruction, both we have anatomic and non-anatomic techniques for reconstruction of the MCL. In anatomic reconstruction, the grafts are anchored to the native tibial femoral footprint, but we need here more graft and more tunnels. It is very difficult. While in non-anatomic reconstruction, we use non-anatomic points for reconstruction. In this photo, we can see this is the Labrad anatomic reconstruction. He had 4 tunnels, one graft separate for the superficial medial collateral ligament, as we see, and the other graft for the posterior oblique ligament with a separate graft. So we have 4 tunnels, and if we have multi-ligament injury, we may have crossing of the tunnels, and this very need experience. Or we may have non-anatomic, we have just femoral insertion for the superficial collateral ligament and the posterior oblique ligament. This photo can present the insertion of the anatomical position of the superficial medial collateral ligament between 3 tubercles, the adductor tubercle and the medial epicondyle and the gastric tubercle. And this can explain the non-anatomic reconstruction. We leave the semitendinosus attached to its insertion and then fix it into the femoral insertion by interference, whatever, and we give the remaining graft to reconstruct the posterior oblique ligament, as we see. This also can show the non-anatomic reconstruction with the triangular shape. We can use interference screw as Kemp's technique, or above and distal, and also we can use suture, anchor, whatever. In Labrad, as I told you, 2 separate grafts with 4 points of fixation. This is an algorithm for medial collateral ligament. And now I will introduce some cases. This case was 70 years old male. He had chronic MCL injury and diagnosed as knee contusion with short elastic knee brace for 1 month. This is his gait coming for this, by this gait with valgus thrust, as you see. This is the X-ray, and this is the MRI. So I decided to do a reconstruction of the medial collateral ligament, but I did non-anatomic reconstruction. This is the hamstring tendon, and then we we anchor the hamstring tendon inside its attachment, tibial attachment of the medial collateral ligament, and then we pass under fascia, and then we we insert it into the femoral point, isometric point, and then the remaining graft did the posterior oblique ligament. So this is the superficial oblique ligament, and then return again to the upper part of the posterior surface of the tibia to reconstruct the posterior oblique ligament like a triangle, as I told you. And also we can fix the superficial collateral ligament 1 or 2 centimeters below the joint line by anchor suture to make it more strong. This is the video after surgery. He had good flexion because we use the isometric point, and also with valgus it was stable. This is the gait of the patient after surgery, early after, about 2 months after surgery. This is the incision. The valgus thrust was disappeared. This is the post-operative X-ray. And it's another cases with, as is this case with the drive-through sign, medial drive-through sign, and we also reconstruct by hamstring tendon. But this patient we have combined ACL and the medial collateral ligament, and also I did non-anatomic reconstruction, as you see. This is the graft for the isometric point of the femoral condyle, and then we return the graft to reconstruct the posterior oblique ligament, and we use interference screw, as you see. And then we return again and fix it again on itself. But we have some complications in conservative management, as residual laxity, valgus malalignment, failure of cruciate reconstruction can result from conservative treatment of medial side knee ligament injury. And the complications of operative intervention, as I told you, arthropibrosis is one of the very important complications when you do reconstruction of more than 2 or 3 ligaments at one time. Also hardware problems, superficial infection, regional pain syndrome, DVT, and the residual instability. So conclusion, isolated MCL injury can be managed conservatively, while grade 3 MCL tear with cruciate ligament injury remains a matter of investigation, as still there is no consensus. More randomized controlled trials may solve this controversy in the future. Complete medial side injury result in anteromedial rotator instability and require precise repair or reconstruction to restore stability, kinematics, and function. Optimized rehabilitation program result in good to excellent outcomes. Thank you.
Thank you so much, sir, for this excellent presentation and excellent case presentation. Very nice case. Thank you so much, sir.
Thank you, Tuman.
Thank you, sir. Our next speaker will be Professor Mohammed Gouda, Professor Orthopedic Surgery and the Head of Orthopedic Department, Banha University. Professor Mohammed will speak about a very important topic, which is graft selection in ACL reconstruction. Professor Mohammed, please.
Thank you so much. A part of this important session, and I'm very happy to share our experience with each other. Thank you so much, Professor Al-Ashhab, for allowing me to be with you. And please, I want to share.
Yes, please, sir.
Screen. Is that okay now?
لا حضرتك افتح البرزنتيشن دكتور محمد بيه وبريس شير.
انا فاتح البرزنتيشن وبريس شير سكرين زوم.
لا مش ظاهر لسه.
ستارت برودكاست.
شير اللي هو الجرين باتون تحت.
دكتور محمد اوريدي انا عامل اوريدي بس هو بيحمل ولا بيعمل ايه؟
طيب اقفلها تاني يا دكتور محمد بيه وافتحها كده.
حاضر. حاضر.
انت شغال من ايفون ولا
اعمل
من
مين يا دكتور؟ من الايفون يا فندم.
هو الايفون دايما بيعمل مشاكل شويه.
طيب شير
طيب
اهي، شير
افتح تاني،
ولا دور
افتح
ادوس من
تاني،
شير؟
افتح تاني ودوس شير من تحت من
شير
الاخضر.
اهوت. ايوه دوست شير. بعدين شير ايه؟ سكرين بقى.
لا مش ظاهر.
ايه ستارت برودكاستنج. انا كده اهو ستارت برودكاستنج.
ايوه اوكي.
تمام. هو دلوقتي بيحمل. طيب
لا مش بيحمل البرزنتيشن، هو الايفون دايما بيعمل مشاكل في البرزنتيشن شويه.
طيب ثانية واحدة. ثانية واحدة. your screen انتوا دلوقتي اوريدي شايفين سكرين عندي صح؟ كده طيب
يعني
ظهر؟
اوكي كده ظهر يا دكتور محمد.
كده تمام؟
يس يس.
اوكي ثانك يو. طيب والفيديو
Yes.
تمام؟ كله تمام. ابتدي بقى.
اتفضل يا فندم.
بسم الله الرحمن الرحيم. Okay, this talk is about the graft selection for ACL reconstruction. And I think this is a very important topic and a dilemma for every orthopedic surgeon, especially those who are interested in arthroscopy. The point is that we know that we need an ideal graft to be used in ACL reconstruction, but still this is not available till now. Every available graft until now has some pros and cons, and no graft is 100% perfect. The criteria of ideal graft is everything is okay? You're listening to me, Dr. Muhammad? Sir?
دكتور محمد انا سامع حضرتك.
Yes,
بس
yes.
لو ممكن تشيل الصوره بتاعتي من عند حضرتك على اساس
شيلها إزاي؟
يعني هو الايفون
إزاي؟
انا لا هو كده يستوب شيري. طيب شير تاني يا دكتور محمد بيه كده.
I am sharing. أنا كده كده بعدين. طيب معلش. ايوه دي كده تمام يتهيألي.
ايوه تمام، بس شيل صورتي خالص يا دكتور محمد. انا حتى لما بقفل الفيديو بتاعي برضو ببقى ظاهر.
تمام كده.
ايوه
كده تمام. كده
اتفضل
تمام.
اتفضل يا فندم.
عظيم. Okay. The criteria for the ideal graft for reconstruction, it must be biomechanically similar to the native ACL, and it's of course to be easy harvested and has a least harvest site or donor site morbidity, and can be secured predictably and get well incorporated with bone, which is called ligamentization. This is the transformation of this graft into a ligament. And also we should consider some things, especially in primary surgery. The patient demands, the patient who is going to do reconstruction, his demands differs. And so the graft chosen is different. The donor site morbidity, especially in autograft, and the anatomy of the ACL origin and insertion, you have to know it well before doing. And the biologic factors in favor of graft integration and ligamentization, and at the end, the cost of the graft used. We should also consider in choosing the graft in revision, the patient demands, and to investigate the risk factors for to re-rupture if possible. Why did the first one ruptured? We have to investigate this and not to fall in the same problem that we have faced before. If it is related to the type of the graft, you have to change the type of the graft in the second one, especially in revision. And reduce further morbidity of another graft. We know if we, for example, if we took the hamstring tendon in the revision, we may use the ipsilateral patellar tendon. And so this knee will be, or this will be weaker. And if we take the contralateral side, we have now operated on a healthy side. This is a dilemma. We all the time we speak about it. And so we need to further reduce the morbidity of another graft and stimulate graft integration and ligamentization. The patient demands before surgery depends on the kind of sport. For example, the patient is not like the patient just running. A patient with football is not like a patient of basketball. The demands of everyone differs. The level of sport activity, the need of a patient with a competitive athletic activity is not like the needs of an or just a recreational activity patient. Low demands, low demanding amateurs, professional athletes, are they young or are they if he is a professional, but if he is still young or at the end of his professional career, the choice of the graft differs in each one of them. And so also there are modifiable factors that affect the graft choice and non-modifiable factors. The non-modifiable factors, for example, the gender of the patient, the age of the patient, the comorbidities, the notch insertion, the hormonal pattern, these are non-modifiable things. We have to accommodate for it. And also there is some other factors are modifiable, like smoking, the BMI, or the contact sport, or the level athletic activity, and so on. After all of this, the various grafts available for as a donor for ACL reconstruction are firstly and most commonly used the autografts. The autografts, the most important and the first one used was the patellar tendon bone graft. And this is the gold standard graft. Secondly, the hamstring tendon, either the semitendinosus or semitendinosus with gracilis. And the quadriceps tendon, the peroneus longus tendon, and still counting. Other grafts are the allografts, also still the BTB, bone patellar tendon, the hamstring tendon graft, the tibialis anterior or posterior graft, the tendo Achilles graft, and finally the synthetic grafts. The autografts are the most commonly used than allografts and grafts. But still, as we mentioned before, the current situation, there is no ideal graft for ACL reconstruction. And the search is still on for an optimal graft. There are advantages and disadvantages of each graft. Firstly, the BTB graft has historically considered the gold standard graft for ACL reconstruction. Why? It's easy to harvest and can be secured well in the canal of the by interference screws. It has a high stiffness regarding the consistency of the graft. It allows fast bone-to-bone healing within the tibial and femoral tunnel, and has excellent with high level of patient satisfaction on the long-term results, 17 to 20 years. They have shown 83% of patient satisfaction, stable, normal, or near normal knee function. And still, the BTB is the best one to structure native ACL, and still the ligamentization or the transformation into ligament. Still there the possibility, and this is the our fear, all of our surgeons, arthroscopic surgeons, the fear of patellar tendon rupture. And I remember our first cases, we have done almost more than 25 years now. At the night before surgery, I was dreaming bad dreams about possibility of patellar tendon rupture or patellar fracture. The quadriceps weakness also is possible, and loss of fall extension in some patients may occur. But still, the anterior knee pain is the most constantly met complication in ACL PTB reconstruction, and also the difficulty in kneeling and pain on kneeling in patients with reconstructed knee with BTB. Numbness due to infrapatellar branch or saphenous nerve injury, and this should be avoided in patients with occupation or lifestyle requires frequent knee flexion or kneeling. Okay, some thought about contralateral BTB autograft. Oh, there are many benefits and disadvantages of this thought. Why? Theoretically, the contralateral autograft is divided by trauma and surgery and rehab with both extremities. Evidence showed that the course of rehab is easier, quicker, and more reliable. Slightly longer operative time, of course, increased patients' education and new approach to rehab for athletes. We are rehabilitating the two knees at the same time, not just one knee. And safe, but still, this is a safe and predictable return without sacrificing the strength, range of motion, and stability of the knee. Used in patients with who wish to return to sport in a priority. Secondly, the hamstring tendon autograft. This is now, although it is not the standard, but this is the most commonly used all over the world autograft for ACL reconstruction. Why? They are used, of course, they are used as a quadruple tendon if it is used with the gracilis, and double tendon if it is used alone, and maybe used as a triple tendon, tripling, or maybe quadrupling with the new fixation methods, the adjustable loops and buttons. The pros of the hamstring tendon is there is no fear of fracture. You can sleep at the night before surgery. No fear of fracture of patella. No fear of tibial tuberosity fracture. No fear of avulsion of the patellar tendon. And no kneeling problems. Minimize the donor site morbidity. It has an average overall load to failure, a very good to load to failure, 240 K Newton compared to the patellar tendon, which is 1700. And still the hamstring tendon is the best in the post-operative morbidity in comparison with the patellar tendon. But still the cons of the hamstring tendon, it reduces knee flexion, strength, the sciatic nerve possibility of injury and palsy, inferior fixation strength, of course, and short-term studies revealed a very good near to normal results in 1.5 re-rupture rate only, and 15-year follow-up has 75% satisfaction and normal score near to normal in patients with re-rupture rate about 70%. And still the best comparison for the hamstring tendon and patellar tendon, the patellar tendon is excellent long-term stability and still a very strong, reliable graft, but the hamstring tendon is excellent post-operative rehabilitation, and morbidity is very better than the patellar tendon, but still in the long term, there is tendon elongation and some problems, and still inferior than the patellar tendon on the long run. And there are some systematic reviews compared both. Some favor the hamstring tendon and others favor the patellar tendon. And I think after all, as these two grafts are the mainly used graft, one is the more gold standard, which is the patellar tendon. It must be revised to the very competitive athletes who needs very high demanding functions, and still they need to be a very strong, reliable graft. We may resort to the patellar tendon. And those who wish a less post-operative morbidity and earlier rehabilitation, they may resort to the hamstring tendon. And of course, a better post-operative scar. The BTB graft has is declined progressively in the hamstring tendon graft the allograft is still increasing, and I think we have mentioned why now. And this is a microscopic picture of what is meant by integration and ligamentization. I don't think this is the site to say that. Okay, the donor site morbidity, donor site problems led us to search for allografts. Allografts will stop the voices that say there is post-operative morbidity. There is no post-operative. There's shorter shorter operation time. You can choose a stronger graft as whatever you need, and still they are increasingly used in the United. I think about 30% of primary reconstructions are using this now. The pros: it has no harvest site morbidity, predictable graft size. Do we still have time? Predictable graft size.
Yes, sir. Yes, sir. We have time, Dr. Mohammed.
Okay. Shorter operation time, easy to use in multi-ligamentous revision. Of course, we have plenty of grafts we can use, and the easier recovery in post-operative period. But the cons are the disease transmission, immunogenicity, and slow incorporation. This is the all-time complication with allografts. But still, we have plenty of donor sites for allografts, like the Achilles tendon, which you can never use in the autograft safely. We can use the Achilles tendon, and we can. But still, of course, there is the risk of infection, immunogenic response, alteration of graft structure properties by sterilization, and affecting long-term graft stability has deterred some surgeons from using this graft. When comparing these, the reviewer demonstrates that no statistically significant difference between autografts and non-irradiated allografts. And this is a very important point. If we do in vitro studies between the comparison between the autograft and non-irradiated allograft, there is no significant difference between both. But still, the irradiated grafts are more likely to fail because the decreased mechanical properties due to sterilization and possibility of triggering an inflammatory response. And some meta-analysis associated with the graft failure, the allograft graft failure, although reoperation rates, translation, and rotational stability functional outcome were similar. And this led to an evolution of a concern of synthetic grafts. Synthetic grafts, this has passed a very long story. From the start, about 1980, they started using allografts, synthetic grafts, and it was like a revolution in the use of ACR reconstruction. But still, the complication that, especially with carbon fibers, has frustrated everyone. And then a second generation, this is the first generation, and then a second generation of allografts, of synthetic grafts, Dacron, polytetra, fluoroethylene, and so, and has very strong properties like 5,300 Newton. This is very strong in relation to other grafts, but still these ligaments also they allowed ingrowth of other structures, but still they had complications like fraying after a time and low abrasion resistance. And this led to a third generation of grafts. And still, I think we will have a fourth generation, and now augmentation is used, and combination of several types of grafts just to reach the best graft function with the least morbidity and the long time success. And to conclude, the ideal graft is yet to be available till now. The patellar tendon autograft, patellar tendon bone graft, still remain the gold standard, the best integrated and ligamentization, and as we said, oldie but goldie. The hamstring tendon graft is has a minimal donor site morbidity, but has problems with bone tendon junction healing, and still tendon elongation is a problem that we faced during the early 5-year post-operative follow-up. The allograft has poor results in terms of re-rupture rates and immunity, but can be used in multiligamentous injuries or in revisions. Synthetic grafts are still under evolution. No perfect synthetic graft is available till date. And thank you.
Thank you so much, Professor Muhammad. Interesting presentation, sir. We have two questions. First question from أخونا الدكتور عدنان المفلح من اليمن الشقيق. دكتور عدنان بيسأل ACL graft from peroneus longus. Any rule in reconstruction of ACL? Of course, if used, any effect on ankle stability? Dr. Muhammad B.
Actually, I have used this peroneus longus for some time. Just, of course, this is a new thing. I have to test for it. And to be honest, I was not very satisfied with this graft. And still, I was afraid to use it. Weakening of the eversion of the ankle. And there are just two muscles, the peroneus longus and brevis. If we take one, I think still, even after we anchor one of them to the other, still there is some weakness in the foot eversion, and I revised. I don't do it now. I prefer actually for the ordinary patients the hamstring tendon, and in competitive athletes I prefer the patellar tendon bone.
دكتور محمد، وهل من الممكن، والسؤال برضو الباقي اساتذتنا، يعني هل من الممكن ان انا for my first choice ان انا ابدا بالبيرونيوس لونجس grafting in reconstruction وانا عندي الهامسترينجز او عندي البي تي بي او whatsoever، ولا ده في اوبشنز يعني selected options ان انا مثلا حصل re-rupture او something like that وانا ما عنديش another way to obtain a graft from hamstrings؟ ولا ايه راي حضرتك؟
شوف حضرتك، هو الجرافت هنا ايا كان اللي هتاخده you will weaken the donor site. Yes. You have 3 donor sites common to be used, 2 main common, and this third one you are asking about. Yes. The first one is the patellar tendon. If you take the patellar tendon, and this is the best one to take, but still you will weaken the extensor mechanism. Yes. If you take the hamstring, you will weaken the hamstring, no way. The knee flexion will be weak, and elongation of and other complication I've mentioned. The peroneus longus is still an alternative. احنا ما رحناش للبرونيوس لونجس الا لاني ستيل احنا بندور على مكان اذا اخذنا منه ما نحسش ان الكومبليكيشن اللي حصلت دي اثرت على بقيه الجسم. هنا النقطه الاهم، ليه الناس فكروا في البرونيوس لونجس؟ لان هنا البرونيوس الكومبليكيشن اللي بتحصل عند الانكل مش عند الني، فهو هنا هيبقى الني الى حد ما بقت ستيبل، وهنا هو معتمد ان الانكل يعني الى حد ما هو عنده الليجمنتس بتاعته قويه جدا، الماسلز اللي حواليه الكونتريبيوشن بتاعها اقل سنه من الليجمنتس، كمان البوني ستراكشر بتاعه ان هو بيفوت جوينت مخليه somewhat more stable، فخلى الناس تطمع في البرونيوس لونجس، بس ستيل انا بخاف منه الحقيقه.
Yes, we have another question, Dr. Muhammad. What type of graft is the most preferable for football players?
Actually, the hamstring tendon, hamstring tendon. Yes. The hamstring tendon for several concerns. They like it. It is very good in the post-operative morbidity. Although the BTB is very good in the strength and the stability, if you have seen this comparison clinically on patients with BTB and patients with hamstring tendon, you will never do a hamstring tendon. But still, me, like most of the surgeons, still we do the hamstring tendon. Yes.
Yes. Thank you so much, Professor Muhammad. Thank you so much, sir. We will move to the next speaker.
محمد أشهب، بعد إذنك بس إضافة صغيرة.
اتفضل يا دكتور عبد الرحمن بيه، اتفضل يا فندم.
وحضرتك بالنسبة للبيرونيوس لونجس جرافت، هي فعلا in the last era Peroneus longus graft was used much more than previous time. The advantage is the knee flexion. The patient started physiotherapy, started rehabilitation early. The knee flexion is becoming very early, and also we faced some problems with the knee extension in these patients. So those patients using Broneus longus had this complication, no complications about flexion extension.
Yes.
But unfortunately, there is no long-term study follow-up of the Broneus longus. So the many centers stopped to use it because we didn't know after sometimes 10 years or about more than 10 years, what about the ankle dorsal eversion and inversion. And some ankle surgeons prohibit this, and they say it will affect more with the time with the ankle eversion and inversion. And so I prefer to use it in multi-ligament injury because I need when we need MCL, ACL, PCL, we use the Broneus longus. This is my comment.
Yes, sir. Yes, sir. This was my question. It's not the first choice, but in
Yes.
selected cases.
I agree. In
Yes, sir.
cases of multi-ligament injury, I use Broneus longus.
Thank you so much, sir. Our next speaker will be Dr. Hassan Zemrli from Italy. Dr. Hassan will speak about ACL perfect tunnel placement. Thank you so much for being with us, sir.
Thank you. Thank you. مساء الخير للجميع.
الخير يا فندم.
Thank you, Professor
سعداء
Muhammad,
بلقاء حضرتك يا دكتور حسن بيه. أهلا بيك يا فندم.
for the invitation.
Yes, sir.
Okay. We are going to talk about the ACL perfect tunnel placement. ACL lesions are very common lesions, and ACL reconstruction is one of the most common operations in sport medicine. The goal of the ACL reconstruction is to restore the normal knee anatomy and kinesiology, but we have a failure rate that ranges from 3 to 11%, and this failure can rise up to 30% in young athletes. Tunnel malposition is one of the most common technical reasons for ACL failure, and small changes in tunnel placement can result in significant difference in outcome. So the proper positioning of tunnels is critical for optimal results. In literature, we have a general consensus about the ideal tibial placement, but there is still debate about the femoral placement. The center of the tibial tunnel should be placed in the center of the native ACL, in line with the posterior edge of the anterior horn of lateral meniscus, and should be approximately 15 millimeter anterior to PCL. It is important to avoid a more anterior position that create impingement with the roof of the notch and a deficit of extension. And also we have to avoid a posterior position that impinge PCL. On the other hand, there are no agreement about the ideal femoral tunnel position. Actually, the trend is for the anatomic femoral tunnel, and the non-anatomic tunnel can lead to residual instability and the graft failure. So the trend now is for the anatomic tunnel. But when we go to place the tunnel, we have a different portal, and there is no agreement on the ideal portal and consequently the perfect femoral tunnel placement. The transtibial approach is the most familiar technique. It was the predominant and most commonly used method for creating the femoral tunnel. But the problem with the transtibial approach is that the femoral tunnel is constrained by the tibial one. And the result can be a vertical tunnel, a steepest graft, and this condition can lead to rotational instability, degenerative change, and inferior outcome. So the more anatomic reconstruction by anteromedial portal has been proposed to closely restore the normal anatomy of the ACL. In the anteromedial portal technique, the femoral tunnel is created by an anteromedial portal. The portal should be medial and inferior to reach better the native ACL anatomy. So in the technique, we have to identify the exact position, generally 40% of the proximal to distal distance on the lateral notch, and the position must be centered between the intercondylar ridge and the posterior articular margin. And the position should be over the bifurcate ridge, like we can see in this picture. The anteromedial technique presents technical challenge. It may create a damage on the femoral medial condyle, and we can have also a posterior fracture, a posterior break of the cortical, because the tunnel is done in a hyperflexion position with limitation of visualization and the risk of the anatomy damage on the posterior cortical and on the femoral medial condyle. So we have some pitfall. It is important at the beginning to identify the exact position of the center of the tunnel. After, we have to introduce the pin and the reamer at 90 degrees. And after, we have to hyperflex to pin and to ream. Can be useful the use of flexible reamer or retrograde reamer. So when we compare the two techniques, the transtibial one is more familiar, but the problem is the vertical and steepest graft. With the anteromedial approach, we have functional superiority, an oblique near anatomic position of the graft, but it is technically challenging. It is difficult to view the notch due to the hyperflexion, the risk of posterior cortical breakthrough, the damage of the medial condyle, and it is important the critically short femoral tunnel, because with this technique, we can have a short tunnel. So we have to use the adequate technique also for a short tunnel. To avoid the vertical and steepest graft with the transtibial technique, we can use the modified transtibial technique. With this technique, the tibial tunnel is created by a different approach with more inclination, so we can reach with this position the exact native anatomy of the ACL. We can also use an outside-in technique. This technique necessitates an additional incision and can be beneficial in obese patients and skeletally immature patients or in revision cases. So the correct tibial and femoral tunnel are very important for the success of ACL reconstruction. The position of the graft directly impacts the stability, the recovery time, and the long-term outcome. Biomechanical, anatomic, and cadaveric studies have shown potentially improved femoral tunnel position when reaming is performed independent of the tibial tunnel. But it is very important to analyze the combination of the two tunnels. And in a recent study, a cadaveric study, El-Jaja found that the steepest and vertical graft resulted in increased anterior tibial translation and rotation and should be avoided. The anterior tibial position of the graft may cause severe extension deficiency, in particular with the transtibial tunnel or with an anterior anteromedial femoral tunnel. And the preferable choice is an anatomic femoral tunnel as far posterior as possible by anteromedial portal in combination with an anatomic tibial tunnel. When we analyze literature about meta-analysis and results, we found that the two techniques present no difference in AKDC subjective score, in Tegner activity scale, in graft failure. But we have a difference in Artometer study, in Lachman test, in pivot shift test, and in Lysholm score. And also, we have an objective difference between the two techniques, but the subjective aspect is similar. And the most important thing is that the graft failure is similar in the two techniques. Evidence support the use of modified transtibial technique with a tunnel more oblique. And the anatomic position of the femoral tunnel can be achieved using the modified transtibial technique. So in conclusion, the ideal portal and tunnel placement for positioning the graft is still debatable. The more anatomic placement can lead to greater knee stability and a more accurate reproduction of native kinematic. Creating the femoral tunnel independently provides the best chance to find ACL footprint. Thank you.
Thank you so much, Dr. Hassan, for your interesting presentation. And we have two questions, sir. Some of our colleagues are preferring peroneus longus graft over the hamstring graft. Of course, it's a matter of different opinion, but what do you prefer in Italy, sir?
In Italy, generally we don't use peroneus graft. We use hamstring graft or bone tendon bone graft. Also in Rizzoli Institute in Bologna, Professor Marcacci used the over-the-top with lateral tenodesis graft with more than 6,000 cases with good results. And also in footballer player, it is a very good technique. But no, the peroneus tendon is only for specific cases.
Yes, sir. Thank you, sir. Another question from Dr. Gamal Qasim. Is there inclination angle between tibia and femoral angles, tibial and femoral angles?
Yes, it is important, the combination of the two angles, because if we have a posterior with the transtibial technique, the tendency is to create a posterior tibial tunnel to reach better the posterior position in the femoral side. So this combination with the two, with a posterior tibial and posterior femoral tunnel can lead to an anterior instability and anterior translation of the tibia and to a short tunnel. So it is important. My advice is to, before creating the tibial tunnel, is to identify the exact femoral position. And after, when we go to do the tibial tunnel, we have to aim on the femoral position. So we can change the inclination of the tunnel and the rotation of the tibia to reach better the native position of ACL. With the anteromedial approach, there is no problem to reach the exact position, but we have it is important with the anteromedial approach to hyperflex the knee, to flex the hip, and the direction of the wire have to be parallel to the horizontal plane. So this is important.
Thank you, sir. Another question, sir, from Dr. Muhammad Osman. Does varus knee affect the placement of femoral tunnel?
It can affect, but it is not easy to consider all these aspects. In our experience, we don't consider the varus aspect of the tibia.
Yes, sir. Thank you so much, sir. Thank you so much, Dr. Hassan, for being with us. It was an honor, sir. Thank you so much. Our next speaker will be my dear friend, Dr. Srinivas Khampati from India, and he always attends our online meetings, and he's a great support to our online course. Thank you so much, Dr. Srinivas, for being with us and for your elegant presentation, which will be about your unique technique in meniscal repair using long hollow needle. Thank you so much, my friend, for being with us.
Thank you very much, sir. Thank you very much for the invitation.
Thank you, my friend.
Good evening, respected speakers and delegates. Once again, thank you, Professor Elashab, for this opportunity in this wonderful meeting. It's an honor to be part of this forum. I'll be talking about an inside-out meniscal repair technique that has been evolving, and it's an improved version. It was developed primarily to cut costs to repair meniscus in patients who are unable to afford expensive techniques. I had presented an earlier version of this in the Egyptian Orthopedic Association meeting in Cairo about 3 years ago. Now I'll be presenting an improved version of this technique. I must disclose that I'm developing a device related to the technique of this talk. So meniscal tear repairs are of 3 types. And of the 3 types of repairs, inside out is the gold standard. Other option is partial meniscectomy, and we have no information on how many menisci are being saved in the patients operated under economical schemes. There's no difference in failure rates and clinical outcomes between all inside and inside out repairs in recent literature. All inside has lesser operative time and lower nerve injury compared to inside out repair. There is recent evidence of higher failure rates in all inside repair in elite athletes, especially when used for medial meniscus. Outside in is the cheapest and all inside is the most expensive. An inside out repair is done using solid needles and zone specific curved guides, but requires special assistance and equipment to apply. There are different techniques of doing inside out repair, and more new techniques are being added recently. One technique has been described wherein the author uses a solid needle with an eye in the far end for passing the suture. So they pass with two passes into the meniscus on either side of the tear and pull out the suture. In my previous technique, I used a long hollow needle of about 15 to 20 centimeters, and this did not require trained assistants. Note the way the suture is loaded into the needle. This was developed to cut costs in procedures done under the schemes. There were no guides required for this technique. The same needle may be used for outside in suture of the meniscus, and multiple passes can be done into the meniscus using the same needle. The cost of inside out repair was reduced using this technique. Needle was reusable and economical, and it just cost the suture for the patient. There was no additional kit required, and the needle was always available in case an unexpected requirement for meniscal repair in any case. So this video is a demonstration showing the previous technique using long hollow needle. The needle is of 16 gauge. Fiber wire is fed into the needle as shown. The needle along with the wire is passed into the joint through the anterolateral portal through one side of the meniscus tear, and it exits through the skin. The fiber wire outside the needle is pulled out until the free end comes out, and the needle is then withdrawn into the joint having the wire inside, and an appropriate point selected on the opposite side of the tear to place a vertical suture, and the needle penetrates the meniscus again to exit through the skin, and this time the suture from inside the needle is pulled out, and this leaves the needle empty. The needle is retrieved out of the portal, and thus we have a suture running across the tear of the meniscus. So the challenges with this technique are related to the size of the needle. 16 gauge is a larger hole needle, and 18 gauge is a finer needle, but it's too flexible. Loading of the suture also may be difficult into the needle, and there's limited safe zone laterally and the inability to repair the posterior horn of the meniscus. The advantages of 16 gauge needle is that it is stiff and it is easy to pass. It was preferred before, but it makes a bigger hole in the meniscus. Although I have not had any problems with this in the cases that I have done, I would prefer a smaller hole in the meniscus as there is a potential of hole propagation when you pass the needle, and it may be difficult in thin peripheral segments of meniscus. 18 gauge needle is better and has a smaller hole profile, but it is more flexible and bends when you attempt to penetrate the meniscus, as you can see in the video. And this can be overcome by using a sleeve, a blunt guide, which can be made from the previous 16 gauge needle, which also avoids the scuffing and portal feeding issues. We overcame the challenge of feeding the suture into the needle by using vacuum suction attached to one end of the needle and suture fed through the sharp end. It just takes about 2 seconds to feed the needle this way. Feeding thicker fiber wire is easy manually into the 16 gauge needle in our previous technique, but when we reduce the diameter of the needle to 18 gauge, the fiber wire should be of size 0 or 20. And these sutures are very flexible and difficult to pass manually. And they take a long time to pass and sometimes impossible in wet conditions made by the irrigation fluid. So this tip comes in very handy to reduce the time to feed the suture into the needle. And we have published this in the journal Curious. The modification includes 18-gauge needle for better hole profile. 16-gauge needle is modified and used as a sheath to prevent the 18-gauge needle from bending. And the same technique is used to pass the suture across the torn meniscus. So in the first pass, the suture outside the needle is pulled out. And in the second pass, the suture from inside the needle is pulled out, leaving the needle free of the suture and the suture across the tear of the meniscus, as seen in the video. So this is a device that is developed and is being refined. This is a clinical case. There's an unstable meniscal tear. One suture is initially passed and the meniscus is stabilized. So using the sheath has the additional advantage of pushing the meniscus and reducing and holding the meniscus reduced while passing the suture. But pushing too hard could actually prevent the suture from sliding. So the pressure must be just right. As you can see, the suture from outside the needle is pulled out first. The needle is withdrawn once the suture is out, and another site is selected to pass the needle. After piercing the second site, the suture inside the needle is pulled out and the needle is removed. I passed around 4 sutures on this meniscus using this technique, 2 on the femoral side and 2 on the tibial side. And you can see the final reduction after that. So the expense for the patient is just 2 fiber wires for 4 sutures on the meniscus. So that's the reduction. This is a follow-up 1 year. 1 year follow-up of a revision repair of a bucket handle tear of medial meniscus. It was done for a recurrent tear following a significant trauma after repair of a bucket handle tear. Is doing well. We've done a few cases using this technique. Medially, the safe zone for repair is larger than the zone laterally due to the presence of the common peroneal nerve. So we performed a cadaveric study and found that the risk of common peroneal nerve injury laterally is reduced and mitigated by flexing the knee to more than 120 degrees. If the knee is flexed 90 degrees or less, the risk of impaling the nerve is very high. So the wires are passing very close to the nerve and they actually go through the nerve. The high risk to posterior neurovascular bundle to repair the posterior most tears remains. So the posterior horn tears are ideally repaired using an all-inside technique. And this study investigates the risk of common peroneal nerve injury by measuring the nerve's proximity to the trajectory of a straight needle inserted from the anteromedial portal at the knee joint level during inside-out lateral meniscus repairs in ACL injured versus normal knees. This has been accepted in archives of bone and joint surgery. There were 30 ACL injured knees and 30 normal knees. By drawing a reference line 1 centimeter medial to the patellar tendon at the joint level to the lateral margin of the popliteus and extending the line posteriorly and measuring perpendicular distance from this line to the common peroneal nerve, we compared the anatomical differences between the two groups. Common peroneal nerve is located significantly closer to the reference line in ACL injured knees. The mean distance is 1.5 centimeters compared to normal knees, where the mean distance was 2 centimeters. This suggests that a higher potential risk of nerve injury in ACL injured knees is present during inside-out meniscal repair procedures. So we have seen that common peroneal nerve has a risk, but MRI is performed in an extended knee. So if we flex the knee, like we have seen in the cadaver study, to more than 120 degrees, the risk is mitigated completely. And the potential meniscus available for repair using this technique is much more in that position. So what we have seen in the MRI study is that the common peroneal nerve can be closer than we thought in ACL injuries. So one needs to be careful because the position and relation of structures after injuries can change. Potential complications are the same as for any inside-out technique, and these include saphenous vein and nerve injuries, sartorius and semimembranosus entrapment, and neurovascular bundle injury. To summarize, inside-out repair is the gold standard. Repair using a long hollow needle is economical, fast, and easy. It's easily done for low-cost cases. Newer modifications improve the utility of this technique, and more experience and large-scale studies with this technique are required to establish its utility in all types of meniscal tears. Thank you very much.
Thank you so much, Dr. Cernibes, for this unique technique of meniscal repair. And sir, we have one question for you from Dr. Gamal Qasim. Can long hollow needle technique gives the same results as the traditional other techniques? And what are the specific measures and precautions?
We have not actually compared in studies with other techniques, but the results are good from the cases we have done. It's just like any other inside-out technique. So I would say, ideally, we should have some studies conducted to compare to evaluate the results between the two groups.
Thank you so much, sir. We have no more questions. And by your talk, sir, we have finished the first section of our day about the ligamentous and meniscal injuries. And now we will come to the next section, which is knee arthroplasty, either total knee arthroplasty or hemi-arthroplasty, partial knee replacement. And our first speaker will be Professor Wael Nassar from Ain Shams University. Professor Wael will speak about which knee for which patient. Professor Wael, please.
Assalamu alaikum.
Alaikum assalam.
Thank you for inviting me to this marvelous gathering. And I hope I can manage to take you through a short journey talking about different knee designs. And at the end, I hope we can reach a consensus to select which knee design is suitable for each group of patients. Dr. Mohammed, slides is progressing?
Yes, sir.
Okay. Knee replacement surgery is a solution to knee pain in over 300,000 patients each year in USA. More than 50 total knee prostheses being operated every year in our hospital university, in Shams University. About 10 to 12 total knee in Demirtaş, which is the government hospital. Aseptic loosening of total knee arthroplasty is the most common cause of failure in both the unconstrained and semi-constrained types of prosthesis. 70 to 80% of cases had the diagnosis of osteoarthritis. 10 to 15% are rheumatoid. Other indications are much less common and include tumors around the knee, vascular necrosis, for one or more of the femoral condyles, geriatric pelvic fractures, which is a new evolving indication these days, and other rare causes. Egyptians are slightly different from other patients. Patients usually seek medical advice in advanced stage of the disease where more conservative techniques and arthroplasty has no rule. Varus deformity is much more common than valgus deformity. Flexion deformity is almost in every patient. Recurvatum deformity is less common. Most cases has severe varus with severe internal tibial torsion. Many Egyptian primary total knees are comparable to difficult revisions in other countries. Augments, blocks, and extension stems should be available on call or on shelf. This is one example of a primary total knee that we see every day in Egypt. The patient usually neglects going to do the operation until a very advanced stage in the disease. What are the goals in total knee arthroplasty? Pain relief, returning of function, maintaining stability, and of course the durability of the prosthesis. And this is the target of our presentation today. The targets is good component position, restoration of limb alignment as much as we can, and we can, of course, go into a long discussion about alignments, whether classic alignment, mechanical alignment, kinematic alignment, or modifications. Balanced collateral ligaments, equal gaps, and suitable implant designs. What are the variables? Age, activity level before the operation, and the expected activity level after the operation, extent of pathology, deformity associated, bone deficiency, and instability. So which is more important, the surgical technique or choice of the implant? Of course, both of them are important, but in my opinion, surgical technique still takes the upper hand, although after propagation and innovation of robotic surgeries and navigated surgery, surgical technique and patient and surgery skills becomes less and less important, but in my opinion, it is still the most important factor. There are some principles to guide the design of the prosthesis, which replace the diseased or worn articular surfaces while retaining the ligament and muscle. The component should be shaped to allow distraction, sliding, rolling, rotation between the bones. The component should apply only compressive stresses to the juxta-articular bone. All surviving soft tissue should be kept and restored to their natural tension, and the areas of contact between the prosthetic surface should be large enough to maintain the pressure under load at a level which the prosthesis can withstand. With new replacement designs, you could see the patient walking just 2 hours after the end of surgery, and this puts the base of fast-track surgery, which is becoming more and more available these days. The success of knee arthroplasty is a multifactorial issue. It is the interaction between implanted design geometry and the surrounding soft tissue structure, stability, which serves to determine the range of motion, interface forces, and stability of the articulation. The implanted design consideration, we should consider the constraint of the prosthesis, the load-sharing ability, the interface forces, tibiofemoral conformity, contact stresses, and kinematics. What do we mean by constraint? Constraint is the amount of inherent or built-in stability that the implant provides, starting from unicompartmental, going through mobile bearing, then gender-specific, cruciate retaining, cruciate sacrificing or substituting, posterior stabilized, then constrained condylar, rotating hinge, and finally, the most constrained fixed hinge. This is the graph showing different designs starting from the very unconstrained to the extremely constrained types. Constraint should be weighted against contact stresses and load sharing. The more conforming the prosthesis, the wider the surface area of contact, the less wear, and vice versa. We can take this example of high heel shoes against the military shoes. Although the high heel shoes is more elegant, but the prints it causes in the floor is much more permanent and damaging. Although the military shoes may be ugly to some, but it distributes the forces over wider area, decreasing the contact pressure and decreasing the wear. Conforming the joint surface over the best wear resistance, but conflict with PCR retention and rollback with kinematics of the knee causes greater fixation stresses. If we choose to maintain a PCL although it's tight, this may cause reversed rollback, may cause flipping of the prosthesis, and increases the contact pressure, the wear, and consequently accelerating the aseptic loosening. So the PCL should not be left until its competence and efficiency. If we start from the least constraint design, the unicompartmental knee, unicompartmental knee arthroplasty, which will be covered later during this night with my colleague, it is mainly indicated in a unicompartmental disease for young and middle-aged, patellofemoral articulation grade 1, 2, and some centers until grade 3, minimal deformity because it's not aiming at all to correct the deformity, and in my opinion, it's contraindicated in rheumatoid arthritis. It needs a functional ACL, but nowadays, some centers, even if the ACL is deficient, they are doing ACL reconstruction with a unicompartmental replacement. Good range of motion preoperatively is a must. It's not the good choice in osteonecrosis. Indication for uni replacement, unicompartmental disease with major or no affection of other compartments, grade 1, 2, and some centers up to grade 3 patellofemoral cartilage degeneration are not a contraindication of medial or lateral unicompartmental disease. Limited patellofemoral replacement is not widely used, and most designs available does not give satisfactory long-term results. The next step in constraints ladder is the mobile bearing. Mobile bearing allows some rotational movements ranging from 12.5 in some designs up to 25 degrees in other designs. Also, some mobile allow anterior-posterior movements mimicking the rollback and roll forward of the normal knee kinematics. It's used in young, active, stable knee, and this is a must. Balanced collaterals. It gives better results with better kinematics and improves the proprioception of the patient, especially in down stairs. It's low chairing, better conformity, less contact pressure, but it cannot eliminate the problem backside wear. Types of bearing designs, it may be a meniscal bearing, rotating platform. Some high flexion knee designs are still mobile bearing and dual track knees. This is some examples of rotating mobile bearing where it allows only rotation. This design allows rotation with anterior-posterior translation. The next step in constraint is screw sheet retaining. To use a PCL retaining prosthesis, you have a good range of motion. You maintain the femoral rollback, gives better position, near normal stability, ligament control, control forces, prosthetic cement bone interface, and wear. Posterior cut out of the PCL relatively is less conformity. The problem of PCL is it's very difficult to judge that this PCL, an arthritic knee, and more important, a rheumatoid knee, is functioning and stable in the long-term use of the patient. Fixed high flexion knees, some design modification from the normal knee, especially in the posterior condyle of the femur and in the tibial polyethylene. As we see here, the posterior condyle of the femur is shorter, thicker, and more rounded than the fixed, than the non-high flexion in the picture below. And the picture in the left side is for a patient 1 year after the operation. This is 6 months post-operative X-ray, and the one lower down is 2 years post-operative, showing more than 130 degrees of knee flexion. The modification in the polyethylene is seeing in the anterior part of the polyethylene, where we removed part of it to allow for patellar ligaments so that there is no friction between the patellar ligament and the polyethylene, and to allow the high degrees of flexion. Also, it's generally recommended if we use the high flexion designs to replace the patella with it. This is the modification I mean in the posterior condyle of the femoral component. It is thicker, shorter, and more rounded. Modification in cut area designs nowadays is to remove an extra cut from the posterior condyle of the femur to allow for the thicker component to fit, not affecting the flexion gap. Few years ago, this design was introduced from Japan, which is the bisurface knee prosthesis, where there is 3 articulating surfaces, one for the medial femoral compartment, and one for the lateral compartment, and a third one in the middle compartment. It has a unique ball and socket joint in the middle posterior portion of the femoral and tibial component. It's one of the posterior stabilized designs without cam and post technique. No box cut. It causes femoral rollback, which prevents posterior tibiofemoral impingement. It has 3 contact areas so that it has more wear and more earlier loosening. But unfortunately, this design does not stand the test of time, and after a few years, it disappeared from the market. Another design, which is the track PS mobile bearing total knee, where there is 3 articulating surfaces also. All these designs aim at distributing the forces over a wider area so that decreasing the wear, but the end result is not as the designers wanted. Posterior stabilized, it can be cam and post or deep dishing of the tibial polyethylene. How to substitute the PCL mechanism? Either we use the cam and post technique, or we increase the dishing of the polyethylene as in medial pivot designs, or we use the hinges. The cruciate substitution, it allows enough correction of the deformity, whatever severe, fixed varus or valgus or flexion deformity more than 30 degrees. You can never correct it except by using cruciate substituting with removal of the box. It's an easier technique, easier than balancing and balancing the PCL.